Bismillah ar-Rahman ar-Rahim. Dear doctors, today with one of the most common respiratory problems in ICU, acute respiratory distress syndrome, ARDS. Firstly, we'll start with definition of acute respiratory distress syndrome. The first accepted definition for ARDS was presented to the world in 1994 American European Consensus Conference definition, which was updated later in 2011, which is Berlin definition. And there are actually minor differences between both of them. Both definitions describe ARDS like acute onset of acute respiratory failure with bilateral opacities in post-lung fields on chest X-ray or CT scan. Both definitions ruled out the cardiac origin of the problem, but in different ways. In the first definition, by measuring pulmonary artery wedge pressure or occlusion pressure to be below 18, which is actually not practical that much because it's not usual to insert Swan-Ganz catheter on every ARDS patient. Now it's more realistic, just do echo and rule out LV problem. It's more simple and more applicable now. And last point is the classification. Previously, in the old definition, it was classified to acute lung injury and ARDS according to BF ratio, PaO2 over FiO2. If BF ratio from 300 to 200, it's acute lung injury, and if it's below 200, it's ARDS. But nowadays, they omitted the acute lung injury term completely, and if the ratio below 300, it's ARDS, which could be classified to mild, moderate, severe. Mild from 300 to 200, moderate from 200 to 100, severe, which is below 100. So the minor differences, as you see, Berlin definition speaks about clear onset, 7 days. It wasn't defined in that one. Of a known risk factors. Of a known risk factor. And now we can rule out the cardiac issue by doing echocardiography instead of inserting Swan-Ganz and measuring the wedge pressure. And the new classification, which ignored completely the acute lung injury term, but in the new definition, the patient should be on a PEEP of 5 centimeter water, at least. So simply, it is acute respiratory failure with bilateral opacities, which is not cardiogenic in origin. How does it happen? On the left side, this is the normal alveoli, outlined by 2 types of cells, type 1 and type 2 alveolar cells, interstitial space, and the blood vessel, outlined by endothelium. So this is the barrier between both of them, alveolar or blood alveolar space, blood alveolar barrier by endothelium, interstitium, and alveolar epithelium. What is happening simply is inflammatory damage that breaches that barrier with flooding of protein-rich plasma in the interstitial compartment and then inside the alveolar space. This damage is mediated by multiple types of inflammatory cells and the cytokines, especially interleukin 8. This stage is called exudative stage. Exudative stage. And this fluid inside the interstitium and alveolar space is full of protein and the various types of inflammatory cells and platelets and red blood cells. As you notice also, there is microvascular thrombi as a part of the pathogenesis as well. Later on, the sequelae will be one of two scenarios. Either the recovery scenario, proliferative stage, in which all types of cells proliferate again with recovery. So as you see, the alveolar cells recovered again and they start to secrete surfactant again, and they try to pump back this fluid out through the lymphatics. So there is ongoing recovery here. Proliferative stage. Endothelium also proliferate again to heal. But here, for some reason, some patients proceed to fibrotic stage, in which the fibroblast and the myofibroblast predominate in the scene and causes fibrosis everywhere inside the alveolar spaces, in interstitium, on the blood vessel, and lymphatic vessels as well. So we lose the lung, literally. So 3 stages: exudative stage, fibrotic stage in terms of recovery, or fibrotic stage in terms of complication. Okay. What are the causes or differential diagnosis of ARDS? Determination of the cause is extremely important in the management. So we can classify it like pulmonary or direct cause. We have a long list here, most commonly pneumonia, but could be due to aspiration, could be lung contusion, near drowning, inhalation injury, but pneumonia is still on top of this list. The other list is extrapulmonary or indirect, non-pulmonary sepsis, either abdominal, UTI, catheter-related septicemia, whatever. Massive transfusion, multiple trauma, massive burn, pancreatitis. All are possible causes of ARDS. On top of this list is non-pulmonary sepsis. So we would say pneumonia and non-pulmonary sepsis are the most common causes of ARDS in ICU. Now let's move to diagnosis. We need to collect information to diagnose the condition. So firstly, we'll move with history taking. We need to determine the cause, because we need to manage the cause to get control of ARDS situation. And then we do some investigations like chest X-ray, CT chest, echo, EBG. Chest X-ray, as you see, bilateral infiltrates, both sides, of acute onset. CT chest will do the same job, even it gives you valuable information. As you see, it's not homogeneous distribution. It's mainly in the dependent dorsal parts of the lungs. Very clear now, the ventral parts are better aerated than the dorsal parts. It can tell you also, as you can see, this blackish circles. This is recruitable lung. So these parts can be recruited by the ventilator. But doing CT in a patient who is severely hypoxic, deeply sedated, paralyzed, could be dependent on vasopressors is quite a challenge, and it is not safe. It's not always safe to be done. So I wouldn't do CT chest unless it's completely safe in terms of the patient transfer. Echo, very important to be done according to Berlin definition. As we mentioned, we need to rule out that it's not acute pulmonary edema, simply. So doing echo now is the way to do so. Of course, we need some clinical judgment about that, and also history taking would help, because the patient might have chronic heart failure with ejection fraction 30%, and now he's on ARDS for some reason. So we need to prove that this is not acute pulmonary edema due to acute left side heart failure, something like MI. So cardiac enzymes would help, the echo would help, history taking would help. EBG is very important. We need to know about PaO2 and get PF ratio to classify whether the patient is mild, moderate, or severe, as we mentioned before. And some sophisticated investigations, it's not always necessary to be done, like extravascular lung water, which can be measured by PICO device, and it will be very high, of course, extravascular lung water. Now let's go to management. The first step, which is always ABCD optimization: airway, breathing, circulation, disability, CNS. AP is the specific treatment as well today. So simply intubate the patient. Don't waste time trying NIV in ARDS patients unless a rescue treatment until you are ready to intubate him. NIV has no rule at all in managing ARDS. So I would intubate, ventilate the patient directly, and we need to do what's called lung protective ventilation, or simply low tidal volume ventilation. This lung is very restrictive, as you know, so we need to give him very small tidal volume, which is 6 ml per kg, but ideal body weight. Very important, ideal body weight, not the actual body weight. And this is the formula, this is the equation for ideal body weight. So we need to collect that one, then apply 6 ml per kg as a tidal volume. Respiratory rate according to the BH and the BaCO2, and we can increase it to maximum of 35. And the other two, PEEP and FiO2, will be discussed the next slide. But what about the mood? No single study determined that there is ventilator mood which is superior to others. Many moods tried in ARDS patients: volume controlled moods or pressure controlled moods, like inverse ratio ventilation, BC inverse ratio ventilation. There are some specific moods like APRV and high frequency oscillatory ventilation, but there is no superior mood over the others. You can try a volume controlled AC, you can try volume control SIMV, as you like. What is the optimum PEEP for that patient? This is the most important question today, because we simply deal with restricted, atelectatic, inflamed lung. We need to recruit that lung. So the problem here, if you put too low PEEP, the alveoli will keep collapsing, especially the surfactant level is low, so it will add more and more alveolar trauma or atelectic trauma. And if you put too much PEEP, there will be a risk of overdistension, barotrauma, and biotrauma with the release of more cytokines and more ARDS. So what is the ideal PEEP or optimum PEEP? You have two ways to determine this. Just on the mechanical ventilator, search for what's called pressure volume loop. This scale for pressure, this one for the volume, and you will find it like this. In ARDS, you will find it quite different. And as you notice, that part of the curve, this is the inspiration and this is expiration. So during that part of the curve, the pressure is increasing with no much increase in the lung volume, and then all of a sudden we have that surge, that slope, where the pressure, when the pressure increases, the volume increases dramatically at that point, which is called lower inflection point. And the situation will be like this until you get that point, which is upper inflection point, and again the pressure keep increasing with minor increases in the volume. So I would say PEEP is any point between the lower inflection point and upper inflection point gonna be a good PEEP for that patient. So you give him a pressure level in which it gives you good lung volume, not below the lower inflection point and not higher than the upper inflection point. Mostly start with the lower inflection point. But to use that method, we need to paralyze the patient completely. There should be no straining, no cuffing, nothing, to be more accurate here. And um, this is the disadvantages of that method. So it's not practical. We need to paralyze the patient completely. So most physicians use that method. Just apply PEEP and FiO2 according to that table. If the patient is moderate or severe ARDS, start with moderate PEEP like 10 with 60% of FiO2, like 12 with 70%. If he's severe enough, just go for 14 and the PEEP of 8, 14 of PEEP and FiO2 of 80% directly, and move with both of them according to the response of the patient. So this is called PEEP FiO2 table. Very practical, very quick. What are the targets of mechanical ventilation in ARDS? We need to keep PaO2 above 70. Because the ventilation is low volume ventilation, actually, it's gonna be logic that the BCO2 would be quite high, but it's okay, it will not kill the patient. This is permissive hypercapnia, so don't try to correct it to the normal values, as long as the pH down to 730 or even 725 on some literature, but it's okay. This is permissive hypercapnia, no problem. This is the accepted pH. Down to 730 is fine, or even 725, no problem. Plateau pressure, which is the indicator for the barotrauma or alveolar damage, shouldn't be higher than 30. The last target, the driving pressure. Driving pressure is the plateau pressure minus the total PEEP, and we need to keep it below 15. How to keep all these targets by mechanical ventilator? If you have a problem with plateau pressure, it's always above 30, we need to move down with tidal volume. Just give lower tidal volume. Go to 5 ml per kg, ideal body weight, then to 4 ml per kg, ideal body weight, until you control the plateau pressure and keep it below 30. If you have a problem with CO2 making the pH unaccepted level, just increase the respiratory rate with the maximum increase to 35. Try to control the pH above 7.25, but the patient CO2 is very high, and the patient now is very, very acidotic and out of control by the mechanical ventilator. Extracorporeal CO2 remover might have a place here. How to optimize circulation. An impressive study, fluid and the catheter treatment trial, was conducted on over 1,000 patients, trying to compare the conservative fluid management group and the liberal fluid management group. The first arm patients were net balanced after 7 days, and the second group patients with liberal fluid management were quite positive, very positive, 7 liters of positive balance after 7 days. And guess which group was better in terms of oxygenation and improvement of the lung pathology? It was the first group, the conservative fluid management group. Significantly increased oxygenation, better lung injury score, and more ventilator-free and ICU-free days. So it's very clear now the positive balance is deleterious on ARDS patients, especially the pathogenesis itself is fluid movement from the alveolar capillaries to inside the interstitial space and alveolar space. So it's quite logic that we should avoid the positive balance. So this is the conclusion we have. Try to keep at least net balance, or even negative balance if the patient's hemodynamics tolerate. If not, just keep net balance would be fine, but never ever to keep the patient on positive fluid balance. Try to avoid this. For D, the sedations, there are no studies discussing which type of sedation and how deep should we sedate the ARDS patients, but the usual rules apply here. Light sedation, emphasis on analgesia, try to wean sedation completely as soon as you can, and early mobilization. All those terms of practice improve the outcome in mechanically ventilated patients with ARDS. Deep sedation, especially with benzodiazepines for long duration, unnecessarily increase the mortality. Some tips could be done when you put the ARDS patient on mechanical ventilation, especially if you have severe ARDS range with PF ratio less than 150. If you got such a patient with PF ratio less than 150, you have to paralyze the patient, not only to sedate him, because the ventilator parameters for this patient would be quite high. This patient on a PEEP of 12, PEEP of 14, so we need to paralyze him because it improves the respiratory mechanics and the chemistry between the body and the high mechanical ventilator parameters, and lowering in the same time the oxygen consumption. So all studies considered NEMPIX or CISA-TRAC as the best option to paralyze the patients, and it should be used for less than 48 hours. If you have the same patient, the same severity level, PF ratio less than 150, early and severe patient like this, so we need also to consider seriously to prone the patient, pruning position. The value behind prone position, as you know, the pathology predominate dorsally, and the ventral parts are better aerated than the dorsal part. So when we prone the patient like this, we get more blood supply to the ventral parts, so increasing or improving the matching between the ventilation and the perfusion. And also the cardiac weight is down now. It's not over the lungs. Now the cardiac weight is away from the dorsal parts, and as you notice now, the dorsal parts of the lungs or the lower lobes are much better aerated now. If you notice the difference between both parts here, dorsal parts here look white, very white, and now restore its patency again, and its nice black color here. So it helps to improve the VQ matching on the ventral parts because it's better aerated, and it helps to recruit the dorsal parts of the lung as well. This is the rule behind prone position. We need to do this for 16 hours a day, and it does reduce the 20-day mortality compared with keeping supine ventilation. Very important, proning position.